Hello, everyone, and welcome to today's webinar, Humoral Response After SARS-CoV-2 mRNA Vaccine in a Cohort of Hemodialysis Patients and Kidney Transplant Recipients. I am Michelle Ashton of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Diasorin. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Professor Sébastien Hantz, Senior Medical Virologist in the University Hospital of Limoges, France. Head of the Department of Infectious Serologies, Deputy Director of the National Reference Center for Herpesviruses. Professor Hantz, you may now begin your presentation.
Thank you very much for the invitation to speak about our work that we did in our University Hospital in Limoges, France, about the humoral response after COVID-19 vaccine in a cohort of hemodialysis patients and kidney transplant recipients. To summarize some points about the COVID-19 pandemic, just a few days ago, there was more than 170 million people infected over the world, and more than 3 million doses of vaccine, 3 million of deaths over the world. So this pandemic was was an urgent need to fight, and these data are available from the WHO website. Some word about the virus, the SARS-CoV-2. To better understand the different assays that we will use after, and to better understand why all the assays are not equivalent. So the virus that everybody well known today is composed from an RNA. It is the genome. And this RNA is protected with a nucleocapsid, thanks to the protein N. And the virus is an enveloped virus. In this envelope, the protein spike is responsible from the attachment of the virus to the cell. On the right part of the slide, you can see the three-dimensional structure of the spike protein in the conformation, where you can see the different essential domains that are represented in the figure A. In green, you can see the RBD, the receptor binding domain, that allowed the virus to attach the ETE receptor on the surface of the cells. And after the attachment, the virus can enter into the cells. Other domains of the spike protein are essential. You can see the N-terminal domain in blue, and the domain S1 and S2. And we will talk after of these different domains for the humoral response against the spike protein. After the infection of the virus, you can use different assays in a laboratory diagnosis to detect the virus or to detect the response, the immune response to the virus. So in this figure published last year, you can observe that the virus begin to be detected, some by PCR, very early in the infection, and just before the week before the first symptoms, the virus can already be detected by PCR, and the detection this assay is this assay was chosen to investigate a COVID-19 infection over the world from the beginning of the pandemic. This early detection explained what some people could transmit the virus to other people without symptoms. After the onset of symptoms, the PCR is always positive, and you can observe in this figure that the immune response begins to appear after the first week. At the beginning, you have some IgM antibodies, and then appears IgG. And after 2 weeks, in general, you have antibodies in almost all people. And then the replication of virus decreases, and the PCR begins to become negative, and at the same time, antibody detection could continue to be a method to detect past infection. To complete this data on humoral response post-infection, in this excellent work published in Nature Medicine last year, the authors showed that median time to seroconversion was D13. As you can see on the figure, with depending from the time, you can see that there is an increasing level of IgM in blue, and an increasing level of IgG. After 3 weeks, in general, you can observe that the level of IgM begin to decrease. When we compare severe and non-severe form, clinical form of COVID-19, you can often observe that IgG titers is more important. IgG titers are more important if the form is severe. And an important point that we observed during this pandemic, more than 1 year after the beginning, is that the antibodies, anti-nucleocapsid, decrease more rapidly than that antibody against anti-spike protein. So when you are some months after infection, you can sometimes not detect anti-N antibodies, but continue to detect anti-S. And in the last publications, it was written that anti-S IgG can be detected until 12 months after infection. And these antibodies are correlated with protection because the risk of infection decreased by nearly 100%. So against this new infection, there was only, until now, only one mean, the vaccination. For it is very interesting to look at the number of vaccines in clinical development at the 8th of June. So 2 days ago, there was more than 100 vaccines in clinical development and almost 200 vaccines in preclinical development. So it's very enthusiastic to see that a large number of researchers, of manufacturers have developed vaccine or try to develop vaccine. So in this research, actually, we have 4 vaccines available in France. The vaccine from Pfizer, the Comirnaty or BNT162b2, the vaccine of Moderna, mRNA 1273, the vaccine of AstraZeneca, Vaxzevria, and the vaccine of Janssen, COVID-19 vaccine Janssen. I show the name of the vaccine in different cycles, and the cycles are proportional. The size of the cycle are proportional to the number of vaccines available on our territory. Numbers. A lot of studies have been performed to explore the immunogenicity of the vaccines and then the efficacy of these vaccines. But when we read with attention all the paper, there is a different exclusion criteria in these studies, and among these criteria, you have known infection with HIV, hepatitis C virus, or hepatitis B virus. But what is more important for our concern is that no people with immunocompromised condition or history of autoimmune disease, no of such people have been included in these studies. And naturally, no people with previous clinical or microbiologic diagnosis of COVID-19. It's logical. So, first we will look at the results of immunogenicity of the most used vaccine in France, the vaccine from Pfizer and the vaccine from Moderna. And concerning the immunogenicity in healthy people, the first publication of Walsh in the New England Journal of Medicine last October showed that concerning anti-S1 antibodies production, the response is different depending on the age of participants and naturally depending on the number of doses. In this protocol, the induction was done with 10 microgram to 30 microgram of BNT162b2. And you can see on the figure that the response is very similar, whatever the quantity of antigen administered. But what is more interesting is that the second dose, here 3 weeks after the first, enhance the response. It's a real boost, as you can see. And interestingly, the best results were obtained with 20 microgram, as you can see here, whereas 30 microgram are not the best doses. So this first result of immunogenicity are very interesting, and when you compare the result of older participants, you can see that the response is really lower because the scale is logarithmic. So even if the size of histogram seems similar, the difference is very important with the response around 10,000 for young people and 3,000 to 8,000 with 30 microgram in older people. Always in healthy people, because no immunocompromised patients were included in these studies, it's interesting to look at the neutralizing response. The assay was done with the SARS-CoV-2 virus neutralization test, and we evaluate the 50% inhibitor. We done with a 50% inhibitor dilution. So the like for the evaluation of anti-S1 response, we can see that there is important difference between young and older people because the range vary from 1.7 to 4.6 times the GINT of the convalescent serum panel among participants. participants, among young participants, and 1.1 to 2.2 times the GINT of the convalescent serum panel among older people. So these first results show that the difference between both populations is induced by the decrease of efficacy of immune response with age. So when we will look at the response of immunocompromised patients, who are often older than healthy people, you can imagine that you combine two factors of lower response. Another result of immunogenicity in healthy people with the vaccine of Moderna, to see that the response are very similar between both vaccines in healthy people. The seroconversion was analyzed was observed, in all participants by the at day 43, wild-type virus neutralizing activity capable of reducing SARS-CoV-2 infectivity by 80% or more detected in all participants, with GMT response to more than 300 in the 25 microgram group and more than 600 in the 100 microgram group. More recent study shows the study of Anderson, published in New England Journal, showed that mRNA vaccine from Moderna induces specific IgG response and neutralizing antibodies in adults older than 70 years of age. So it's interesting, but the difference was similar between older and young population, like with Pfizer vaccine. Some publications have described the response after vaccination in immunocompromised patients. And what the authors said is that vaccines tend to be most effective early in the course of renal disease. So you have to vaccinate as soon as possible. Response often weaker than immunocompetent patients. And that's why they gave recommendation for vaccinations early after diagnosis of renal disease, or if possible, before graft. These recent recommendations were published this year. And another publication, an older publication, but said also interesting point that the types and doses of immunosuppressive agents administered may have an effect on vaccine immunogenicity. Studies have found that mycophenolate use was associated with decreased seroresponse to influenza vaccine in kidney transplant recipients in a dose-dependent fashion. So we will talk again about this point in our study. So why we are interested with patients, with our patients, is that there is no efficacy data available in immunocompromised patients in the first studies of COVID-19 vaccine, as I just showed you. And in parallel, naturally, in parallel of our work, other teams have working on the same on similar studies, and these studies were gradually available from March to now. Our colleague from Strasbourg in France have rapidly showed that in a short report they published the result of the efficacy of the first dose of vaccination, of COVID-19 vaccination in kidney transplant recipients. They observe the response in 250 seronegative kidney transplant recipients, and show that, as you can see in the figure, a lot of patients stay seronegative, and the level of response is very different from a patient to another. The difference with our study is the vaccine used. It was Moderna, and they show that two characteristics are significantly associated with a lower response. It is the time from kidney transplantation. More you are an old kidney transplant recipient, that is the time between the transplantation and the vaccination, more the response is low. And another characteristic is very important, is the immunosuppressive regimen used, and we find again in this study the role of immunosuppressive regimen in the low level of response, as already published for all the vaccine in 2011. The same team continue to follow the patients and analyze the response after the second dose. And after the first dose, there was around 10% of response, and after the second dose, immunization rates reach 48%. They analyze at the same time the impact of different immunosuppressive regimens, and mycophenolate mofetil seems to be very implied in the low response. The steroid again also, and tacrolimus is responsible also from lower response than cyclosporine or low calcineurin inhibitors. So there is a real impact of immunosuppressive regimen. Concerning the hemodialysis patients, there was a study published recently that show the response is vary from a patient from another, but 93% of patients have a response post second dose. It is very different from kidney transplant recipient, and that's why the recommendation regarding vaccination is different between both groups. But the level of response is very different between patients. And we note also that there is a decrease, as shown in the last figure, right? There is a decrease of the level of response with the age. Concerning our study, we recruited hemodialysis patients, 78, 74 kidney transplant recipients, and 7 controls. Naturally, the local research committee gave its authorization for the study, and the French Commission for Data Privacy gave an authorization number for the study. The control group was constituted by members of the medical staff vaccinated between February and March 2021 and included in the institutional post-vaccine follow-up program of the University Hospital of Limoges. Concerning the vaccine use, all the patients and controls were vaccinated with the Comirnaty from Pfizer. Different reasons for this choice. It was the first vaccine approved by French health authorities, and that is validated for such vaccination in immunocompromised patients. The schedule was 2 doses of 30 micrograms, 28 days apart. This vaccine is composed of mRNA, as you know, enveloped with lipidic nanoparticles that allow to enter the cells and allows then the production from the mRNA of the spike protein. The antibodies developed after introduction and stimulation of immune response are naturally anti-S antibodies with RBD antibodies. The efficacy, essentially in immunocompetent patients, was proved with a decrease of excretion and decrease of duration of severe forms. Concerning the workflow of the study, the blood samples were collected from D0 to D58. Then there is screening of infected patients to exclude them from the study. Then we evaluate the seroconversion post-vaccination. We try to determine antibody specificity with a new test, and then we begin to perform neutralization assays. The different methods of the study used were the Alinity SARS-CoV-2 IgG assay from a bot to detect antibodies by chemiluminescence against the protein N. The result of the assay was 1.4. Then we used the SARS-CoV-2 IgG trimeric from diazorin on the liaison analyzer to perform the evaluation of the seroconversion. The result of the assay was assay, and and the range of the assay was from 1.85 to 800. After 800, you can derivate the serum to obtain the real value. And as I precised just before, we used a new test, completely manual test, based on ELISA technology by colorimetry to analyze the specificity of antigen because this assay is allows to detect the response against N protein and the response against subunit of S protein, S1, S2, N-terminal domain, and receptor binding domain. Some word about this test, which is very nice and allow to bring some additional information, but it is not automatized, so it's very long to practice and not adapted to large screening strategy. But for our assay, you will see that it had some very interesting information. So the results are very easy to read because if you read N, that it corresponds to anti-N antibodies. If you read S, it corresponds to S1 anti-S1 antibodies. If you have the NTD detection, it corresponds to anti-NTD antibodies. And in blue here, you have the localization of anti-RBD domain, and in black here, in the left, you have the anti-S2 antibodies. Our strategy to determine patient serostatus was on the first serum at D0 to screen with the Abbott test against N protein. All the positive results were considered as COVID-19 infected prior to vaccination, so excluded from the study in order to compare only people naive from contact with COVID-19. All negative screen samples were included in the study group of vaccine immunogenicity and tested with the licensed SARS-CoV-2 trimeric IgG test. Concerning the profile of patients described here, all the data will be soon available in a publication in the Journal of American Association of Nephrology. The paper is accepted 2 weeks ago. So just some points concerning the age of the population. You can see that our control group was younger, with around 50 years old, comparison with hemodialysis patients or kidney transplant recipients. The sex ratio was similar in each group. Concerning the different pathology that are responsible for hemodialysis or kidney transplantation, there is no big difference between both groups. And we to evaluate the immune response after vaccination, we use another parameter because all these patients are vaccinated against hepatitis B virus, and we analyze the response against this virus, against this vaccine. We analyze also albumin level, lymphocyte count, and naturally the immunosuppressive regimen as was already described in the literature that the suppressive regimen could have an important impact. And for hemodialysis patients, we examine also the PET-V ratio to determine if there is a link with the response. Concerning the seroconversion rate, here you can find the final results published, but we continue the analysis over time to follow up our patients. You can see the very important difference and a very low seroconversion rate in kidney transplant recipients, only 10% at the 58. So, in contrary, the hemodialysis patient respond like in the other publications of that I showed before, with around 90% of response, and the controls have all seven controls have 100% of seroconversion at 2 weeks after the first dose. So the difference is very marked between this group, and it is represented in the figure, the right of the slide, where you can see in parallel of the apparition of antibodies, you can see the different level of antibodies with a large dispersion of value in hemodialysis patients, even in people that respond to the vaccine, and the better response in controls. To look at the antibody titers more precisely, you have the first dose at the 0, second dose at the 4 week after. So the level of antibody is very different between groups, and you have to be careful for the level of kidney transplant recipients, because 2 patients have very high level of antibodies. So, and you can see the sigma test sigma value, to explain that the mean is not very good, is not representative from response of from the level of response of kidney transplant recipients. When we examined the correlation, the HBV vaccine response in hemodialysis patients, we find a very good correlation between titers of anti-SARS-CoV-2 antibodies and titers of anti-HBs antibodies. The difference are very significant between between the patient who are negative, who have a negative response after hepatitis B vaccination and versus intermediary response, and it is also significant between negative and high titers. We found other factors associated with response in hemodialysis patients. There was no relation between diabetes, gender, BMI, and antibodies production. However, we observed higher antibody production in patients aged under 75 years compared to those aged over 78, suggesting that antibody response was associated with age. In addition, serum albumin and KT-V ratio were also positively correlated with serological response, respectively. To better understand the response in such patients, we try to determine the specificity of antibodies. That's to say, against which antigen of the spike protein the antibodies are directed. Until now, we have only tested 55 samples. All other experimentation are ongoing. And the test, we wanted to look at the results between 1.85 and 13. Between these results are considered as negative with the IgG trimeric S test, but when we look at the follow-up of the patients, all the patients with such titers developed a better response in the following samples. So that's why we have 40 patients in this group and only 3 patients in the group inferior to 1.85 and 12 patients on the other group, positive. So we can note that there is a very good specificity because when the IgG trimeric test is under 1.85, there is no response detected in the COVID-diag assay. Concerning the positive test with IgG trimerics, 2 were negative with COVID-diag, but it was results close to the threshold, just around the threshold, and they were positive on the next sample. So it could be also a limit of the COVID-diag test in sensitivity. What we observe with this test is that there is polyclonal antibody response in vaccines that is robust, and among 32 positives, we detected 15 patients with 15 samples with polyclonal antibody response, and among and 10 of them were have IgG turmeric results over 40. Here, it's an example of the kinetic of antibody, and you can see, depending on the day after vaccination, the apparition, I'm sorry, it's a little small, but you can see the apparition of antibodies on the different well of the test. At the top, it is the kinetic of hemodialysis patients, and in the bottom, you can see the control healthcare worker, where the apparition of antibodies is begins at 2 weeks after vaccination. After this test, we wanted to know if the serum of our patient could neutralize virus. So we developed an assay in our NSB3 laboratory in the teaching University Hospital of Limoges, where we collected positive samples from patients. We have we developed viral culture of COVID-19, and then we test the serum of our vaccinated patients that we incubate with viral particle 1 hour, and then we inoculate the sample in aerosol microplates and incubate them between 5 and 7 days. And then we check if there is a cytopathic effect in the culture. Until now, we only analyzed 6 serum, 2 from the control group, 2 from hemodialysis patient, and 2 from kidney transplant recipient. All developed, all the serum tested neutralized the virus in cell culture. So it's very interesting, but all these results should be confirmed on the other sample. In the literature, recently, I find a paper that showed there is, after vaccination, an induction of functionally diverse antibodies against RBD, nuclear terminal domain, and as the part of the protein. So it's interesting that it is result similar with our results. But in this publication, they show also that the vaccination induced a high rate of non-neutralizing antibody. So we will continue our test in our laboratory to dilute our different serum and determine the titer of neutralization of each sample of the patient. To summarize the different results of our study, we can observed that there is a weak rate of seroconversion in kidney transplant recipients. If there is a bias of patient selection, but our patients are often under mycophenolate mofetil immunosuppressive regimen, perhaps more people than in other studies. That could explain that our seroconversion rate in our study is lower. If there is a link to vaccine use, the study of our colleague from Strasbourg used Moderna vaccine. We use Pfizer vaccine. Perhaps the response could have some difference. Our patients are older than in other studies. We note also a good response in hemodialysis patients, like other studies. And what is very interesting is that the response to each HPV vaccine could be predictive from response to COVID-19 vaccine. We have to continue the follow-up to determine the persistence of antibody over the time and to do the different tests of specificity of the different sample and the neutralization capacity. Concerning the perspectives of our in such population, concerning the vaccination, probably the vaccination strategy could be adapted to the population type with perhaps a choice of vaccine different depending from the population. The number of those that should be administered will be different depending from the population type and the interest of IgG anti-S dosage for a large number of immunocompromised patients. Some take-home message to end my presentation. So the kidney transplant patients have not the same rate of seroconversion after vaccination than healthy people, and it's the same for probably all the transplant recipients. Response could depend on the vaccine injected. Response profile could be similar for other vaccination, so it could be indication to observe past response to the vaccine. And serology testing with anti-S detection assay is essential to manage a follow-up of immunocompromised people. I want to acknowledge the nephrology team of our hospital, the virology team, and particularly my technicians of the unit, and Mrs. Lesage and Alibadi of Diasorin for providing the Trimerix assay for the test. Thank you for your attention.
Thank you, Professor Hantz, for your informative presentation. We will now start the Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. Okay, let's go ahead and get started. Our first question is, what are the benefits that you have seen using Trimerix IgG assay?
Before the Trimerix assay was available, we have already used the first assay of Diasorin company, allowing the detection of IgG against S1, S2 part of the spike. On contrary to assay detecting the IgG against N protein, proposed until this time by a lot of companies, assay of Diasorin allowed to check the humoral response after vaccination and have at the same time the ability to detect naturally COVID-19 past infection. That's why we use this test in our laboratory at the beginning of the pandemic. Now, such tests are very relevant for the detection of antibodies in vaccinated patients. It's another step in the pandemic. And a strategy could be coupled both tests with antigen detection in a diagnostic lab and anti-S in parallel in order to differentiate post-infection from vaccination. After this evaluation of primary assay, we can say in our experience that it's very easy to use assay on the efficient liaison Excel analyzer, which can contain many tests on board. The comparison within the COVID assay, the manual test that I showed in my presentation, showed that it is able to detect a large panel of antibody thanks to the antigen of the trimeric protein directed against the essential antigen of the spike, the RBD, N-terminal domain, S1 and S2. So it brings new information than the S1 and S2 assay. It's a real good evolution from the first test, and I want to add a precision concerning the result. Our results were obtained with the first batch of the reagent, not correlated with the WHO international control. So the current batch are now available and designed to give results correlated to this WHO international control. So for people who could use the new batch, they will not be surprised that the threshold of positive result is different from them that I gave in my presentation. Concerning the neutralization assay, the first results that we have are very enthusiastic because all 3 patients have neutralizing antibodies, and the test in the information given by diatherine, the test seems to be well correlated with neutralizing assay. So we want to continue to check this point, and especially in our population, probably where the development of humoral response is more difficult. So I think it's a good test, and that could bring a lot of information in the post-vaccination.
Okay, thank you. All right, your next question. What are the recommendations for the vaccine program in the population of fragile individuals?
Given the risk of severe disease and the high mortality compared to the general population, the French health authorities and the French Society of Transplantation or the French Society of Nephrology, Dialysis and Transplantation recommended vaccination of all previously transplanted patients and, if possible, with immunological monitoring. So it's very important to precise this point. When patients are recent transplants, it will be advisable to vaccinate with it at least 1 month and 3 to 6 months for patients who have received T or B cell depleting agents. And because we saw that the impact of immunosuppressive regimen is very important in the response after vaccination. If possible, for patients awaiting transplantation, it is recommended that you vaccinate with the same strategy, but before transplantation, naturally to be protected at the time of transplantation. In this case, the response will be better, naturally, because the patient have not these patients have not immunosuppressive recipient before transplantation, and there could be beneficiate for the humoral protection just before the graft. And for transplant patients from a living relative donor, it is also recommended that the donor should be vaccinated. As I showed, concordant results of different teams in France and also around the world were observed, and that a low response in kidney transplant recipients, and more widely, probably in all immunocompromised people. This observation drove the French health authority to decide that a third dose is required for all solid organ transplant patients, for all hematopoietic stem cell transplants, patients treated with strong immunosuppression, anti-CD20, and the precise for some hemodialysis patients after medical advice. And if I look at our results, we can note that 10% of hemodialysis patients didn't respond. And probably for such patients, a third dose is necessary and could allow to obtain a response. This third dose should be administered 1 month after the second, and we can add that for vaccine recommendation, it's essential to vaccinate the family circle and people which deals with immunocompromised patients.
Thank you, Professor Hantz. Looks like we have time for one last question today. The question is, how do you see the future for serology testing for COVID-19 in a setting of fragile individuals?
It is a reality that after the introduction of, since the introduction of the vaccination, it's essential now to have in a diagnosis laboratory probably different assay for COVID-19 serology. Probably as we use in house study a test that allows the detection of anti-N IgG because it's important to discriminate people vaccinated from people infected, and essentially for people who have been vaccinated, who have not a good response, and then would develop who could develop symptoms of COVID-19. So it's important for the discrimination to have probably such tests. But now it is essential to have a test that allows to detect anti-S IgG to assess the immune response post-vaccination. And for this test, the performance are critical because you should be naturally sensitive, but specificity is more important in this case in order not to consider a patient as vaccinated if its response is not. Concerning the quantification, it's an important point to allow to determine the characteristic of the patient response and to follow this response over time. We observe different response in current studies that could also depend on the serology test used because antigen are different in the test and correlation with WHO international control not available for all tests. So these points are also important. And finally, the test should be well correlated with the detection of neutralizing antibody because it's these antibodies that are crucial for the protection of for the fight against the virus. So to summarize, it's essential to follow the humoral response post-vaccination in fragile patients with well-validated tests in order to know if your patients are protected, if he needs another dose, for example, for to have the example of hemodialysis patient, patient under weak immunosuppressive therapy. We have often the question from clinician or from patients that want to know if patient we treated with weak immunosuppressive therapy have responded to the vaccine. And in such cases, the level of response should be a criteria to decide to revaccinate or not.
Thank you, Professor Hantz, for your time today. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.